Good morning and good afternoon. I'm Fern, as Gloria said, and I will be presenting a fairly practical session on disability-adjusted life years and using them in cost-effective analysis. In particular, about how to calculate DALYs from an estimate of number of HIV infections averted. Given that we are at a distance, we're not seeing you, I thought I'd introduce myself first. I'm a lecturer in the economics of HIV, and I've been at the London School of Hygiene and Tropical Medicine and working with Charlotte since 2000, so it's been quite a while. I did my PhD on microbicides, on the demand for microbicides in South Africa, and looking at approaches to stimulating uptake and predicting uptake. And I'm very interested in new HIV prevention technologies, and also I do a lot of cost-effectiveness analysis and thinking about resource allocation in HIV and sexual and reproductive health. And in my free time, you can see the pictures of my two girls here, and hopefully this will make it a little less virtual. So welcome everybody. And so as a learning lab, I'm hoping that by the end of this session, you'll be able to understand what DALYs are and think about how you might be able to use them. And I'm going to present a very simple Excel model, and I'm not sure if, and I will send it out to those who are interested in actually receiving the Excel spreadsheet to walk through how you actually, quite in a lot of detail, what you need to put into this model for it to pop out DALYs averted for your own use. Then very briefly I'll talk about matching DALYs with costs to obtain an incremental cost effectiveness ratio. And so hopefully this will be a fairly practical session that will provide you with some fairly practical skills. Now I was just curious, I'd set up a poll to see responses because I was quite curious to know how many people are familiar with DALYs. In a classroom session, I can get you all to raise your hand. So it's slightly virtual for me here. So it'll go from the fairly basic, but hopefully it will also just give you some intuition on how to interpret DALYs if you do not want to get into the nitty-gritty. But hopefully you will bear with me through some of the detail. I will be following the approach in the paper that was circulated to you based on the Fox-Rushby and Hansen paper, Calculating and Presenting Disability-Adjusted Life Years in Cost-Effectiveness Analysis. And that kind of handholds you through the calculations and thinks about and tells you a bit more about DALYs. So for background on this, but also if you want to go off and do them, please refer to this paper. So an overview of the session today is I'll talk about DALYs, what they are and how they're used. Then we'll go into quite a bit of technical detail on what inputs you will need to find and use to put into these spreadsheets. I'll give a brief overview of the Excel spreadsheet. We'll talk about incremental cost effectiveness analysis. We'll talk about including treatment costs averted, and talk about some points of controversy and the importance of using a sensitivity analysis in your results, and we'll conclude. So a disability-adjusted life year is a measure aiming to bring together both years of life lost as well as years lived with disability. Often in HIV, as an outcome, you'll have cost per HIV infection averted, you'll have cost per life years gained, which is only the loss of life. But DALYs and its sister measure QALYs, which is more used in high-income countries, aim to bring together both the quality of life as well as years of life lost. And the aim is to be able to compare health outcomes across different diseases and support decision-making on that. So DALYs, just a brief history of DALYs, they have been developing over a number of years as a collaboration with the World Bank, WHO, in really trying to think about priority setting in healthcare and global burden of disease measures. It's used both to, so this is developed over time, and we'll tell you a bit more about how it developed as we go on. I don't want to spend too much time on it. Just to start off and starting to raise issues, disability-adjusted life years, there's a big, long calculation, and it's the very last slide that you'll all have. I'm not going to present it. But intrinsic in the disability-adjusted life year are a number of assumptions that are represented by these questions. So is a year of healthy life gained now worth more to society than a year of healthy life gained sometime in the future? So DALYs aim to allow you to think about investing in ambulance services and compare with preventive services. So preventive interventions obviously will have a very long-term impact versus something that helps immediately. So in doing so, we use a discount rate to be able to compare future values with current values, and I'll talk a little bit more about what discount rate can be used, but traditionally a 3% discount rate was used. And this represents the fact that there is uncertainty both in costs and effects, and people tend to value the present more. So would you prefer to invest in a life year gained today versus a life year gained 50 years from now? And often people state they'd prefer it now. Same with money. You see people are very willing to borrow money, and the interest rate represents the amount that people, interest rate minus the inflation rate represents the amount that people are willing to pay more to have money now than later. So that's what the discount rate is about. The second big issue that has underlying social values in it is how should we compare years of life lost through death with years lived in poor health or disability of various levels of severity. And so the way that DALYs approach this is by using disability weights, and we'll talk more about that. So they do go through a whole survey asking people, would you prefer 1 year in perfect health versus 5 years in a wheelchair, or how many, it's a trade-off that people make, and through that you can derive social values. Initially, these disability weights were set by a small group of doctors or experts in WHO that sat together over a weekend and set them down. That was subject to a lot of debate, and they have updated that now, and I'll talk a bit more. Question 3, are lost years of healthy life valued more at some ages than others? An important difference with QALYs and DALYs is that DALYs uses an age weighting. It uses age weighting in the formula that implies that a year of life for young adults is valued higher than a year of life at a very old age or in infancy. And intrinsic in this is the social value of people and their earning power and contributing to society. This is subject to debate and has been changed, and people do vary it. In the newest round of global burden of disease, they took out this age weighting. WHO has not, so we'll talk a bit more about that. And are all people equal? Do all people lose the same amount of health through death at a given age, even if there are variations in current life expectancies between population groups? So DALYs tend to be calculated as something to avert from an ideal life expectancy. The longest living population are Japanese women. So they take the standard of, I can't quite remember what it is, 88 years, and they say, okay, if you die at 56 years, you have then lost 32 years. This is, in the global burden of disease, they use the same weights for all countries. But for cost-effectiveness analysis, it's important to think about local decision-making and local life expectancies. And again, I'll talk more about this. So these are just some of the social values underlying the DALY estimates that are in the global burden of disease and in the equation. So I want to give you an example of how DALYs have been used, and maybe some of you are familiar with this. This is an example from the Global Burden of Disease 2010, which has just come out, and maybe some of you have seen the Lancet papers that have been coming out over the past year. This shows the global burden of disease as represented by DALYs. You can also represent it by life years lost or lives lost across different years. Of particular interest to us would be the HIV, AIDS, and TB, or particular interest to me, although, of course, STRIVE is broader. We can see that there is a higher burden in the African countries in terms of total DALYs lost, and in South Asia, this very high peak of DALYs lost is also a representation of population size. Today, what I would like to focus more on, rather than the global burden of disease, is using DALYs in cost-effectiveness analysis. So this figure shows how many DALYs you can avert with $1,000. So if you had a choice between different HIV prevention interventions, you could avert, I don't know how much this is, let's say 20 DALYs using ART, whereas if you decided to treat STIs with your $1,000, you could avert about 350. So DALYs, in this sense, helps you compare across different types of interventions and think about where do you get the biggest bang for your buck. So I hope that's given you a bit of a background. Now I am going to go into some of the more nitty-gritty details, and hopefully you'll find that interesting. So what are DALYs made up of? So a DALY per HIV infection averted consists of years lived with disability. If you think of someone becomes infected with HIV, there are a number of years lived with disability pre-AIDS. Then as they progress, there's years lived with disability with AIDS, and then there's death, and there's years of life lost, depending on how long they end up living in these two states. With the arrival, with the era of ART, of course, there's a huge difference between whether or not you have access to ART. So if you want to think about the DALYs per HIV infection averted, you will need to take into account the level of coverage of ART. So if you wanted an average DALYs per HIV infection averted, you would need to use a weighting. So you have the years lived with disability pre-AIDS or pre-ART initiation. Then you have a level of access if you have 50% or 60% ART coverage. You then multiply it. This is your weighting to obtain your total number of DALYs averted, or your average DALY averted. To estimate DALYs averted, there are a number of inputs that you will need to get. Some of them are fixed. Some of them you will need to seek out for your own country. In particular, with cost-effectiveness analysis, it is far more desirable to use locally specific inputs rather than the international inputs used for the global burden of disease. You need to know at what age the disability occurs, so at what age they become infected with HIV, and then how long that takes until they move to the next phase, whether they So within HIV, you have 3 phases or 3 groups, 3 estimates of years lived with disability. One is pre-AIDS for everyone. Then you have AIDS with access to ART, and then you have AIDS with no access to ART. The age at onset of disability is the same for both of them. The duration of the disability, of course, is very different, whether you have access to ART or not. And the disability weight is also different. And these disability weights have been updated, so I will provide them to you, and I wouldn't suggest changing them. Then at death, there's age at death and life expectancy at age of death, because you are then thinking about how many years of life have you lost relative to a given standard. You also need to use a discount rate to ensure that you to be able to calculate and make calculations between these DALYs occurring at different times. You need to use a discount rate. Age weighting, we'll discuss pros or cons to using age weighting, and you need your ART coverage levels. Here I'm making some suggestions about where you can get what your options are and where what sources you may want to access to complete your calculations. So age at onset of disability would be average age at incidence. Could be specific to gender if you're doing a FSW, or population if you have an intervention among female sex workers, or a youth intervention, or so it should be specific to your population. The duration of disability, you could use a generic one from Murray, the original global burden of disease. But of course, as more information becomes available, this is changing. So a lot of different values are being used in the literature. Pre-AIDS, you can use 8 years. I have also used 3 years. So depending on your threshold for introducing your CD4 threshold cutoff at which people will have access to ART. In the absence of ART, once AIDS sets in, traditionally 2 years was used. But in the era of ART, evidence is showing that life, of course, is extended by far more. So you might have an extended life of 14.4 years, or as we're seeing over time, that actually life expectancy is approaching nearly normal life expectancy in higher income countries. So use as much country-specific data as you can find. Then there's a disability weight. So as I mentioned, these have now been updated. So these are very hot off the press. This paper with the new disability weights came out fairly late last year. And so this shows the impact of the state with respect to one. One would be full health and how much you need to remove from that due to the disability. So obviously the largest disability is caused by AIDS when there's no ART, pre-AIDS, and then if you do have access to ART, there's a fairly small disability associated with that. For your discount rate, you can get it from the central bank website, although there is some controversy about that because it may or may not represent well the social discount rate. Globally, people use 3%. These, if you're comparing across countries. More and more, they are moving to country-specific discount rates. Age weighting will depend on your values, whether or not you find it important that the people in their productive ages are given a greater weight. And it is very important for HIV, obviously. So in the 2010 Global Burden of Disease study, they have moved towards not using this age weighting, although WHO still recommends using age weighting. So if you decide not to use age weighting, you will set K in the equation, and I'll show you as we come down to 0. If you do want to include age weighting, you set the parameter K to 1. And then you need your ART access. Years of life lost, so there you need the age of death and life expectancy at the age of death. So if you die at 80, you may have a life expectancy of 3 years, whereas if you die at 20, you have another 50 years to go, something like that. So make sure that this is consistent with your years lived with disability. So you need to, for HIV, you need age at onset of disease plus the duration of pre-AIDS plus the duration of AIDS until death, to make sure that's consistent. To get life expectancy at age of death, you use the EX column in the gender-specific WHO life tables here, and I will show you exactly what that means in the next slide. Generic global burden of disease studies use the Japanese gender-specific life expectancy, but for research allocation, it's important to use country-specific values. If HIV has affected life expectancy, use pre-HIV life expectancies. Now, with the arrival of ART, life expectancies have been extending quite a bit recently. 5 years back, it had a big impact on some of the high prevalence countries, so you could see a drop in life expectancy in a number of these countries. But looking at it again now, we see that it has rebounded pretty well. So this is what you'll see if you go to the life tables. You'll see the expectation of life at different ages. So at birth, this is for Malawi or South Africa. Sorry, I cannot remember what I put in. I think it's Malawi. So life expectancy at birth is 57 years. If you die at age between 20 and 24, you can be expected to live another 44 years. If you make it up to higher ages, you're expected to live even to a higher age. So you take these and you'll put it in. Now let's go to the next page. This is the Excel spreadsheets, which I would like to share with you. I have highlighted here the parameters that we'll need completing by yourself, and then there are some other parameters that you will want to change in a sensitivity analysis. So age and onset of disabilities. This is an example from South Africa, where we had an average incidence was around 26.6. Now this is very precise. It does not need to be that precise. Here's your duration of disability and disability weight. You may want to leave those fixed for your pre-ART age. Then you have your duration of disability, and will vary whether you have access to ART or not, and your assumptions about how long ART will extend life. So without ART, in this example, assume that they will have a 2-year lifespan, whereas if you assume a 14.5-year life extension thanks to ART, they'll live another 16.5 years. If they have a full life expectancy, this is your life expectancy at age 35, 34.6 from the life tables. Then you need potential years of life left at time of death, and you can get these from the life tables. And here you get your estimate of DALYs averted. Now I'm going to tell you about a bit of a controversy, something that's not very clear. I have been consulting as I was preparing this presentation with a number of experts here, some who've worked at WHO, others who have been calculating DALYs for years and years and years. And in the literature, people have been calculating DALYs in 2 different ways, and it has a huge implication for the value that you get, and it's not very clear. There is one right and one wrong way, but we're not quite sure which it is. So we will follow up on this with you. So either this is your right row, where you add your years lived with disability for HIV, years lived with disability for AIDS, and years of life lost, and you add them up and you get your 29 years of life lost, of DALYs averted if you avert that infection. However, in the Hansen and Fox-Rushby paper, and the way I've always understood it needed to be done is years of life lost calculation happens quite a few years in the future. See, these pre-AIDS DALYs happen at age 26, These are happening far later. These are happening 10 years later. So we need to adjust these back to the start. We need to get the present value. As you know, an ice cream, you can't add the price of an ice cream in 2000, let's say 1990, with the price of an ice cream in 2010. You need to bring them all to the same common denominator. And to do that, we need to calculate the present value. So down in these rows below, we have used our discount rate to get the present value of these future occurring DALYs averted. So using the discount rate for AIDS, from 1.39 it becomes 1.096, and in particular, the years of life lost calculations are quite different. So I have tried to figure out and to bring the different experts to one common understanding and figure out why we're getting different results before this presentation, because I know this will be confusing to you, and I will get back to you when we have brought the different minds together. But it is something to keep in mind. In many of the estimates that you will find do it in this way. The paper that you have in front of you and that goes through the calculations in a lot of detail calculates it in this way. So if you are calculating it, you need to be very explicit about which way you have done it and probably just present both. And here I have the ART access rate, and so this can give you a weighted average per HIV infection averted of the number of DALYs that you're averting. So ART access rate, so this column shows your DALYs averted with access to ART, and this column gives your DALYs averted without access to ART. If only half of your population has access to ART, you need to weight this, and so this is your weighted average. So that was the most technical part of this presentation, and now I'll move on more to what you can actually do with them. So based on your DALYs averted, you can now compare the outcomes of interventions across different diseases. So you can now compare whether, to get the biggest health impact, you want to invest in road safety, malaria, or HIV, or if you want to invest in gender violence reduction versus ART treatment or pre-exposure prophylaxis. So you can compare across these. To do this, we use incremental cost-effectiveness ratios. So if program A is what already is there, and program B is what you could add, so we look at the additional benefit of adding these. So we use the cost of program B is $26,000 minus the cost of program A is $5,000. So that gives us, for an extra $21,000, we'll get 8 extra DALYs, and this gives us a cost effectiveness ratio of how much extra benefit we're getting for the extra spending. So I'm going to move to evaluating cost effectiveness ratios. So is this $2,560 per DALY averted good value for money? So when you are trying to think about this, there are a number of different approaches that people look at for decision making. The first important thing to do is cost effectiveness ratios. They are relative values. So is it worth doing something? Well, it depends on what you're not doing and how cost effective that is. So you need to compare it with other competing health interventions and think about, is this more efficient use of my resources? However, WHO has provided some more useful guidance on an actual threshold. So WHO suggests that 1 to 3 times GNP per capita is a good threshold. So if you think of a country with a per capita income of $3,000 per year, you would say, yes, this 2,625 is good value for money. It's under that, so it's fantastic value for money. In a poorer country where the per capita income would be 1,000, or 700, let's say, it would be considered over that threshold. And this relates to the idea of labor productivity and contribution to society. So if your average per capita income, that tells you how much individuals are contributing to society. But intrinsic in this, again, is another bias, because it's okay for national decision making, but when you're thinking about global funding decisions, it would bias. The threshold would be higher for high-income countries. So it makes sense within a country's decision-making to use your own specific threshold, but it is not as helpful for global funding decisions. The other way that people evaluate cost-effectiveness ratios is to derive it from national thresholds of what is already being implemented. So, for example, in the NHS, the National Health System in the UK, you can look at the cost-effectiveness ratios of the already introduced interventions and say, okay, from this we can say up to about £300,000 per QALY, which is the alternative to DALYs, it seems to be funded, so that you're deriving the evaluation of that. So that's about evaluating cost-effectiveness ratios. One other note I wanted to make in your costs, and I haven't gone into estimating costs at all. I think that's potentially another session if people are interested about program costs. But when considering the cost-effectiveness ratios for prevention activities, it's important not to miss out on the added benefit of treatment costs, averted, due to reducing treatment. So if you're averting an HIV infection, you have your program costs, but you're also reducing your costs in the long run by not having to treat that person. So it depends a lot whether or not there is access to ART. If you do have access to ART, it depends on the prices of your ART treatment program. So your total incremental costs are your program costs minus your averted costs, and that leaves you with how much, is there a net cost to your program, or is it a break even? So now to draw it to an end, it is very important. We've made lots of assumptions along the way about what's important and our value judgment, as we mentioned. Within the DALY calculations, there are a lot of different value judgments in there. There's age weighting, there's your discount rate, there's which life expectancy to use. So it's very important to be very explicit about the decisions that you make. So if you're using age weighting, you're going to give a higher value to illness occurred by adults of working age, which discount rate you're using, which life expectancies you're using. And DALYs traditionally have missed many important health problems. For example, stillbirth would not be included as an adverse outcome because life only exists from their perspective at a live birth. The 2010 Global Burden of Disease has tried to address some of these criticisms, so they've moved more towards health states rather than specific diseases so that they can capture the broader contributors to impaired health. However, it is very hard to include everything. They have also elicited weights from the general public rather than it being from a small group of experts, so that has improved some of these criticisms, but it's still loaded with assumptions, which brings me to the last point of how important it is to use sensitivity analysis to explore the impact of the different assumptions made. And you need to be very explicit about this and vary the assumptions over both the individual inputs and also the most optimistic and pessimistic inputs to get a range on your DALY estimates, and explore if and when they exceed any given threshold. At what point does it exceed your 1, 2, or 3 times your GDP per capita? We don't have time to talk about how to do these sensitivity analyses in more detail, but again, that may be a future learning lab if people are interested, or we can go offline and do it with a smaller group if people would like it that way. So this brings me to the end of this session. It did take far longer than I had expected, but I hope you're all with me now. I can't look in anybody's eyes, so that's a little bit of an interesting experience on this side. But to conclude, DALYs are a measure that can capture health outcomes across disease areas. You're never going to find a perfect one, right? But it is an approach, it has made that leap to try to help decision makers think about health across specific interventions, and it provides a structure for decision making. So in that way, it's provided an important contribution in health economics and in decision making, but it cannot capture non-health development outcomes. So for the types of interventions that a lot of you are interested in that have multiple outcomes, not only health outcomes, it really doesn't capture all of this. So we need to think about how this could be better included. But in the end, incremental cost-effectiveness ratios are being used in priority settings and do provide us with a rationale. So what I was really hoping to get from all of you is hear about some of your experience on using them, or what might be further support if any of you are interested in trying to apply these. So that brings me to the end of the session. In this learning lab, there are also here some key references. This is the paper that I referred you to, and these have been updated quite a bit. Here is the paper that came out that has presented the new disability-adjusted life year weights using the population sampling rather than just a small expert meeting. And just to make sure that it is recorded, here's the equation, and I'm not going to go into it, but you see it's a very long equation. But for anyone interested, it is in the paper by Fox, Rushby, and Hansen, and we can go through that if anyone is interested. So thank you very much. That brings me to the end, and I look forward to hearing your experiences on using DALYs or thinking about DALYs, or your critique of DALYs.
Very interesting presentation. Thanks a lot. It sort of does a lot to kind of refresh my brain on these measures. I wanted to ask a question on kind of an innovation, a big change in calculating the 2010 global burden of disease, is the assumption of gender parity in life expectancy. So saying that men should live as long as women, even if it's shown that isn't the case in most countries. So this obviously shows much bigger burdens for men than women. And I wondered if you know of any applications that use the same life expectancies for men as women at the local level, because you did state that, for local priorities you would go with not the Japanese women, but what is appropriate for the country. And I think what's interesting here from our point of view is the influence of gender norms and masculinity, how it does affect access to HIV treatment, because more and more it's shown that men basically don't come forward for testing and for treatment. So I'd just like to know what you would say about that.
Well, I'm very curious to hear if people what experiences they have with using DALYs, if people do have experience. The global burden of diseases is very freshly out with the new one, so I don't know all the detail of how they have changed, but it is quite an interesting thing. I think there are loads of, when we think we're not making assumptions, there are loads of assumptions that are intrinsic to the numbers that we put in. So it's really important to be aware and try to be as explicit as possible about what assumptions you are making and the impact on the final number and the consequences of those assumptions. But I think probably in the audience there are probably people who are better placed to comment on the gender norms and what should be versus what is in life expectancy between men and women.
This Does anyone want to offer some reflections on that? I guess it also comes down to whether or not there's biological differences that may, or genetic endowments that might actually, in addition to any social or social-cultural things, influence the life expectancy. I mean, we know, for example, that more male infants are born than female infants. So there may be some sort of biological difference that's feeding into it as well.
But should we not address those then? Is that fair?
I don't know.
Yeah.
I think it's one of those
issues. The thing is, we need to be very explicit about what our assumptions are and how they influence our conclusions. And when they're on the table, then they can be debated. What is fair?
Thank you.
Do we have a second question from Fiona Fleming?
Hi, I would like to ask a question. If you knew somebody with infected with HIV, or even a community infected with HIV, that you were calculating DALYs averted through treatment, if you knew that they were also co-infected with other diseases, say a Helminth disease, would you calculate the DALYs averted if you treated that as well? Would you add the DALYs averted? Say, in your calculations to say, okay, so we averted the HIV, so that's that DALY averted, and we also treated for albendazole for roundworm, and that's that DALY averted, so we'll add those DALYs together. That plus that means that's how many DALYs we've averted. Does that make sense?
Yep. So traditionally, yes, exactly. That's exactly what we would do. Now, the interesting thing is about synergistic treatment. So TB and HIV infection, they often go hand in hand. Treating for one often helps the other. And the disease burden is very interconnected. What they have done, which is quite nice for this very specific, the TB HIV co-infection, is they have specific weights for co-infection. I'm not a TB HIV co-infection expert, but I do know that they have specific weights. So if you were doing something on TB HIV, you can go to the Solomon paper and you can find the co-infection rates and calculate the total DALYs. When they're not as interconnected, I would feel quite comfortable summing up the different outcomes.
Okay, thank you.
Do we have additional questions?
Can I raise a question?
Sure.
If people are interested, I can send the Excel spreadsheet, and I would be quite happy to provide further support if people wanted to have a go at calculating DALYs. It might make sense if there is a small group of people who would like to work through an exercise and then discuss, to have a follow-up on this, or if there is a certain group who would like to know more about doing sensitivity analyses, to have a follow-up on that. So I don't know how the learning labs would address some of these follow-up issues that go in a little bit more specifics, and where we would share a screen and do the calculations, or if there's any interest. I don't know if I should start a poll or something on that, or how you would like to get feedback on that.
I think that what I would suggest is at the end of the learning lab, there is you're asked to take a very short, 1 minute, do a short assessment, and it asks for ideas for future learning labs. And we really encourage people to take the minute to do that because, one, it gives us feedback for our own evaluation. But I would just, if you're interested in participating in some sort of additional work through an exercise or would like a copy of the Excel sheet, why don't you just note it in your feedback as part of that little questionnaire, and then we'll have that on record and we can contact you. I have one question, actually. I'm interested in whether or not, and this may not be something that you know, but do you know of any ways in which the weightings and the rankings of different disabilities varied between the kind of expert group that initially did the exercise and now that there's been more and more effort to try to get a broader cross-section of opinions and perspectives about the disability weighting factors? Are there any interesting case examples of how something was very off?
There's a big fat paper on that. And there's a big fat paper on it. I think it's the Lim paper, and I think it was circulated, and it has a mapping of different risk factors from one to the other, or the Solomon paper probably has the comparison. Because when they wanted to compare between how the global burden of disease has changed over time, of course they needed to use the old weights so they could compare over time, but then do a re-estimate with the new weights. So they have done that mapping quite explicitly. So it's either the Lynn paper or there's a Murray paper. There are a few key papers that are available on that, and I could provide them to you.
Right. Do you recall any specific one?
It has quite a few more. It's far more inclusive now. So things like gender violence feature in there. There's a lot of more social diseases are included. Some of the weightings have indeed changed, but I can't give you an example.
Okay. Yeah. So do we have any final thoughts before we let Fern go? Okay. Well, I want to thank Fern on behalf of the group and encourage everyone to take the moment to fill out the form. And if you are interested in getting some further assistance or maybe doing a small separate session where you can work together with Fern to actually calculate some of this, do note that on your evaluation form. So with that, I think I'll close today's session. And just to let you know that we take all of these sessions and make them available both as downloadable PowerPoints of PDFs on the website, the Strive website, but also as a video on Strive TV. So you can access them by going to the Strive website on the LSHTM website, and that's strive/lshtm.ac.uk. So with that, thank you, and we'll see you all next month.